തുടങ്ങാല്ലേ?
Oh.
Saltanai.
Aneeta.
71. Okay. Nabil?
Okay, sir.
Can we start?
Good evening, everyone. So we are about to start our PG club. I invite Dr. Ajit Kumar VT, HOD Pediatrics, Govt Medical College, Calicut, to introduce the speaker and the topic. Sir, over to you.
Yeah, thank you, Nabil. It's honored to introduce Purushothaman sir. And actually, he does not need any introduction. Because he's well known all over Kerala to all the students, not only from Calicut, from Thrissur Medical College, but all over Kerala. Purushothaman sir is well known. He's a great academician and astute clinician, and he loves to teach. So even during his during the lockdown and the corona period, when there was lockdown, he even without students, he used to teach through YouTube and other medias and the social media, and it's a great it took great interest in not only teaching students but other doctors on various aspects. And his favorite I think is cardiology. One of his I don't know whether this is cardiology case, but he I thought that one of his favorite subject was cardiology. But he's a brilliant teacher in all areas as well. And I would love to hear his class. And we studied, actually, I had the privilege of being having studied in the same institute at Trivandrum when sir was also doing the postgraduate student as postgraduate. So I really enjoyed his company throughout, and if you have any doubts during the class, I think he'll be very happy to during the session as well as after it. And you can always personally message him. He's one of the teachers who loves to teach. That's the most important qualification that any teacher would would aspire to. So thank you, Purushothaman sir, for being here, and along with on behalf of IAP Calicut, I really thank you for taking this class.
Thank you, Ajit. Thank you, Nabil.
And Sarna, he's professor and head of department of Department of Pediatrics, Thrissur Medical Government Medical College, Thrissur. So but one quality that I would like to everyone to know is his love for teaching. Thank you, sir.
Thank you, Ajit, for the kind words. I'm seeing Dr. Vinod and many seniors also in the platform. It's just basics of postgraduate teaching only. It will be going in a slow pace. And Aneeta is presenting. We didn't discuss about the case, so I don't know what is the diagnosis. Just an approach of the neurological problem. So our plan is to hear the case without interruption. Let her narrate the case in a slow pace. And after that, we'll come back again with the discussion of the case. So slowly, Aneeta, you may share the screen and start the history.
Is my screen visible, sir?
Yeah, visible. Can you make it full screen, Aneeta?
Yes, sir. Yes, sir. Good evening, everyone. Welcome to my case presentation. Presenting the case of acute onset weakness. Presenting the case of Kavita Bai, 4-year-old girl coming from Rajasthan, now residing at Vadagara, Calicut for the past 2 years. History is given by her mother and history is reliable. History taken with the help of a translator. Presenting complaint, she presented to a hospital about 25 days back with weakness of both arms and legs of 1 day duration. History of present illness. Illness started with pain noticed over the left leg while playing. Mother made the child to lie down on bed, and rapidly the pain worsened and involved the low back, and within 2 hours the pain progressed to involve the entire...
I'm more a slow pace. There is no need to hurry.
Yes, sir. Rapidly the pain worsened and involved the low back, and within 2 hours the pain progressed to involve the entire backside. At this time, mother tried to lift the child from bed, and she noticed that the child felt floppy and she was unable to stand or sit up or bear weight on her legs. The child was crying with pain. The child was taken to hospital in the next hour, and by that time, the child was not moving the arms or legs or even the fingers or toes. This happens to be around 3 to 4 hours from the starting of the pain. Mother appreciated that the whole body and the limbs appeared floppy, as in weightless. The child could not turn on the bed or sit up. The child could not lift her head up, but she was able to move her head to either sides. She could only hold...
One minute. There is a phone call. You just
Yes,
repeat. 1 minute. Just to repeat it. She was taken to the hospital, whole body, could turn on the bed or sit up. Okay.
And she could not lift her head up, but could hold her head when supported, when the body is supported. And she could move the head to either sides on lying down position. There was no difficulty in breathing or any abnormality of breathing noted by the mother. Mother says that she did not perceive mother's touch anywhere on the body other than her face, although the child complained about pain over the entire body. But on touching, there was no pain. There was no seizure, no altered sensorium or increased sleepiness, normal speech and language, no visual disturbances, double vision, tinnitus, hearing difficulty, facial deviation, drooping of eyelids, drooling, dysphagia, or dysphonia noted. No fast abnormal movement of eyeballs, head nodding noted. No tremor, posturing, or abnormal movements noted. At the hospital, she did not pass urine, and as soon as she was admitted, she was catheterized. And the child did not pass stool also and had to be given medication on the subsequent days through rectum. Only then, only after the medication did she pass the stool. The child did not seem to appreciate bowel or bladder sensation. There is no history of abnormal sweating, flushing, or coldness over the limbs. There is no history of fever, no history of trauma, no headache, nausea, vomiting, hiccups, or abdomen pain, no recent infections, respiratory infections, cough, rhinitis, or GI infection associated with diarrhea or vomiting. No history of breathlessness, cough, or fast breathing. No history of alopecia, oral ulcer, or skin rash. No history of recent immunization or intramuscular injection. No history of weight loss or loss of appetite. After admitting to our hospital on the subsequent days, the child continues to remain bedridden, not moving the limbs, both upper limb and lower limb. Child continues to pass urine through the catheter only and pass stool only after administering medication per rectum. She has been given IV medications, and later another IV medication was added. And she does not show much improvement. So that is about the present illness. Past history, there is no similar illness in the past, no previous history of stroke or stroke-like episodes, no history of tuberculosis or diphtheria. Antenatal history, pregnancy was detected by UPT done at hospital, regular antenatal checkups done, No history of fever, rash, genital ulcer. TT doses, 2 doses taken. USC taken in the first trimester was normal. Quickening felt at 5 months. No history of gestational diabetes mellitus, hypertension or hypothyroidism. Blood test done from the hospital was informed to be normal. USC again was taken in the third trimester and was said to be normal. Mother delivered a term baby by normal vaginal delivery with a birth weight of around 3 kg, and the baby cried soon after birth. She breastfed the baby in the first half hour, passed urine and meconium in the first 24 hours. No hyperbilirubinemia, no NICU admission required. And the mother and baby were discharged on neonatal day 3. Immunization history, the baby is partially immunized. The exact doses of vaccination, mother does not recall, but birth dose is taken and BCG scar is present, and definitely one more dose of vaccination was taken at around 45 days. No other vaccine taken. No history of any adverse effect following immunization. Development history, gross motor, age appropriate, head holding by 3 months, rollover by 6 months, stand with support, and before the onset of illness, the child climb up and down the stairs without support with alternate legs. Fine motor, she reached for objects by 4 to 5 months, mouthing by 6 months. Pincer grasp, mother does not recall. Scribbling by 1 year, 3 months. Do not draw circle or line. Language, cooing 3 to 4 months, bisyllables by 9 months, now talks in phrases, uses pronouns, says stories. Social and adaptive, now she is able to help in dressing, she needs help in dressing and undressing, but identifies all body parts and names common objects. Dietary history, breastfed for 6 months exclusively. Complementary feeding started at 6 months with ragi and wheat and also vegetables. Breastfed till the age of 2 years. They are vegetarian, so take only vegetarian diet. There is decreased consumption of iron-rich foods and dairy products. The diet before illness had 900 kilocalories and 10 gram protein. With a requirement of 1360, so there is a calorie gap of 460 and protein of 2.5. Now at present, the diet during illness, she's fed through nasogastric tube, predominantly is milk based. There is a calorie deficit of 560 and protein seems to be adequate. Family history, it is significant. There's a non-consanguineous marriage. There is one abortion in the mother at the conception age of 2 months. She is a second child, first living child, and mother has history of tuberculosis about 4 to 5 years back. She has taken ATT for 6 months. She was sputum positive pulmonary tuberculosis, and it was said that after treatment, she got relieved of the symptoms as well as the test was normal. No other history of weakness or paralysis in the family. Socioeconomic history, father is a manual laborer, he studied up to 10th standard. Mother is a homemaker, studied up to 5th standard. So according to the modified Kuppuswamy classification, they belong to upper lower class. They have a rented tiled house at Vadagara, 3 rooms, 4 members and good sanitation facility. And presently they are included under the RBSK scheme and is availing benefits. So that finishes the history.
Okay, we'll go back to the history again. You heard the history. To sum up, it's a 4-year-old child, you said, or 3?
Yes, sir.
So 4-year-old child, previously normal, all on a sudden developed a weakness of all the 4 limbs within a matter of hours, and after that it's remaining the same for the last 25 years. Is that the situation? 25 days total?
Yes, sir, 25 days.
There is no improvement.
No improvement.
So before we go in depth about the patient, just a few basics about the neurological problem. Any neurological problem will be going stepwise asking in sequential manner different questions. First thing is there a neurological problem? If it is answered yes, the next question, where is the lesion or where are the lesions? It may be in the brain, spinal cord, brainstem, then anywhere in the motor unit. That means antefrontal, radical, peripheral nerve, minor junction muscle. So in the approach, it will be helpful. Where exactly is the lesion? Anatomical localization. Then next step, what is the pathological basis of the problem? And maybe a few more questions. What is the functional disability which is caused by it? That will be the sequential answering. So we take that thing here again. So you heard the antenatal, natal, postnatal history. Everything was normal. Development was normal, except one thing you said is in the fine motor, is a circle is not drawing. Otherwise, everything was normal. So this sudden onset weakness persisting like that doesn't seem to be any functional situation. So there may be another child a little older, a similar situation you may encounter due to pure psychological situation. So in this case, definitely there's no need to consider that possibility. It's an organic problem. Organic problem. Next thing in the neurological diagnosis to define the disability or the problem. Is it an alteration of sensorium? Is it a weakness? Is it a balance problem? So that's how you move forward. The defining the problem should not be wrong. Some gait problem, balance problem may be due to weakness. So if you go wrong in the first definition, everything after that will be going wrong. So here, what is the basic problem here? It's a weakness. So when a child of 3 or 4 years is brought here with weakness, also she had some pain mentioned. Again, you need to doubt whether is there a possibility of a non-neurological problem presenting as weakness. So second thing, is this a condition due to pain, pseudoparalytic situations? That's one important thing. Sometimes many of the joint problems or other things can also lead to pseudoparalysis. In this case, again, that point possibility is very unlikely, because all on a sudden it happens, all the 4 limbs are involved, there is a bowel bladder problem, very unlikely to be a pseudo-paralytic situation. It's a true neurological problem, most likely in the form of a weakness. Now comes here question, where is the lesion? A paralysis can occur due to lesion anywhere in the UMN or LMN as mentioned. So categorization, UMN and LMN, is it in the intracranial portion, spinal cord, or anywhere in the motor unit? So that's a initial points in the history part she mentioned. There is no alteration of sensorium, there is no headache, raised executive features are not the, no seizures, nothing in the brainstem cranial territory she mentioned. Vision is normal, swallowing is normal. Which are the functional derangements which can happen due to a cranial problem? The opening of the eyes, closing, and the ocular movements, facial expressions, swallowing. So these are all decided by cranial. When there is suppose in this case it is not there, so it's very, very unlikely to be due to an intracranial problem. But suppose there is a situation of any of the territory of the cranial nerve we are having any problem. there is a one question. In that situation, there are two possibilities. It can be due to a parenchymal problem inside the brain or brainstem. There is a remote possibility of a cranial nerve territory involvement due to total peripheral motor unit problem also. So imagine a situation of binaural junction disorder, some of the muscle disorders. You may get an ocular movement problem, ptosis, facial expression problems. So just because in the cranial territory you are having a weakness, don't think that it's due to brain or brainstem problem. Sometimes the peripheral binaural junction muscle problems can also lead to a cranial territory weakness. So how to differentiate, which point will help you to differentiate between these two things? Of course, you may have alteration of sensorium race seizure, which may argue for intracranial, but it need not be, because there can be a pure brainstem problems where you can get the cranial nerve, multiple cranial nerve. That can confuse you with the motor unit, binaural junction and a muscle problem. The main possible point here is the bilateral symmetrical or asymmetrical. Binaural junction disorder or a muscle disorder, and rarely an anti-Honsel Miller-Fisher situation, or will be bilateral symmetrical. If it is a unilateral, that will argue for an intracranial pathology. So I was just saying a case condition where there was an intracranial territory, facial territory weakness. In this case, there is nothing to suggest any of these things. Facial expression is normal, swallowing is normal, voice is normal. When she described few of the points to argue against the cranial nerve involvement, there is some point which you need to go in depth, because few of the manifestations which she described can occur due to some peripheral problem. See, she said about the voice. Voice is important because voice can be involved due to the 10th nerve in the lowermost medulla involvement. It can also be involved due to another problem down. Another situation, there can be a weakness of the intercostal or a diaphragm where the amplitude of the voice is less. So you need a little more of elaboration about the voice and the speech part. The amplitude alone is gone down means it can occur due to any of the motor unit disorders. It need not be lower medullary. Suppose there is something change in the voice in the course of harshness or hoarseness of the situation, that means it can be due to actual the cranial involvement of the vagus. Otherwise, an involvement of the intercostal or diaphragm at the radical or spinal cord level also can lead to low amplitude of the voice. Harshness indicates there is a real involvement of the lower medullary things. And one more reason why you need to ask a little bit more about the lower cranial nerves is because here is a case where you are getting all the four limbs weakness. All the four limb weakness means the lesion must be much higher if it is a spinal cord lesion. It can be due to motor unit disorder, or a spinal cord lesion is what you are going to postulate because none of the intracranial points are there. But few of the situations which is at the junction of the craniovertebral junction, there can be a little bit encroaching of the lower medullary. So craniovertebral junction problems like your dislocation, like your Arnold Chiari, something, many of the malformations are there. So a little bit of the lower cranial nerve involvement can be there. Occasionally, you may get the medullary or even the facial nerve, rarely, because there is an interesting entity, the facial nerve fibers going down into the medulla and looping up. So that way, medullary encroachment can happen. You may get a situation of cerebellar signs. You may get a situation of lower cranial involvement, maybe 10th or 12th or 11th can be involved. Especially the 11th is going down up to the C5. So there can be weakness of the trapezius and the sternomastoid because the 11th is coming down. And the 12th is the lowermost, sometimes it can be involved. And very, very important thing is, there can be suppose there is a vascular involvement very high up, there is a possibility of involvement of 12th. So these are the reason why which you should be concentrating when you take the history, especially about the lower cranial nerves, that sometimes may not argue for an intracranial or a brainstem pathology. It can still occur due to a spinal cord pathology. So we are hearing the possibility of an intracranial pathology responsible is less likely. So it must be down. So now your question is it a spinal cord lesion or is it anywhere in the motor unit? When I mean motor unit, antenatal, radical, peripheral nerve, minor junction, muscle. So element type or a UMN type. So in the UMN type, it must be somewhere from the upper spinal cord down, or if it is an element type, it is anywhere, any of these possibilities are likely. That's what you are considering as a possibility of in the anatomical localization. So which other point will help you to pinpoint where exactly? Aneeta, you just discussed, where do you think out of these discussions, out of this, where are you thinking of the possibility? Is it a element motor unit disorder or is it a UMN where you think it's a spinal cord problem, or in that situation where?
So there is a symmetrical involvement of all muscles according to the history. And bowel bladder is also involved. So I think it should be in the spinal cord.
So I'm not agreeing with your first argument. It's a bilateral symmetrical involvement of weakness of the muscles. That does that argue that it is
in the spinal cord? Yes, sir. But along with that, we have.
Is it so? Is it so? In a
Sir,
GPS where the radicals are involved, it can be bilateral.
Yes, sir.
So minor junction disorders will be bilateral. Muscle disorders of acute onset like myositis or whatever, that can be bilateral. Some of the channelopathies of the muscle disorder that can be bilateral. So is bilaterality is not an argument for the UMN or spinal cord. But the other one is, of course, that is the point. It's not the bilaterality. On many of the, so which among the motor unit disorders, starting from the antenatal, radical, peripheral nerve, minor junction muscle, which among will be asymmetrical? Can be asymmetrical. Many of them are bilaterally symmetrical. Which among the motor unit disorders can be asymmetrical? That's especially relevant in this case.
Sir, infectious myelitis like polio can be asymmetrical.
Most important in this case, she had only one dose of OPV. So, even though that's so rare in this case, but when you discuss this thing, that is one of the motor unit disorder where it can be patchy, asymmetrical. Anything, anywhere else you can, any other pathology in the motor unit where it can be asymmetrical? You think about
so traumatic neuritis can be?
No, peripheral nerve. There's no need to go into pathology. Now we are discussing the anatomical localization. You stick on to that, don't go to the pathology. So where is the lesion is what we are discussing now. Radicals, it will be bilaterally symmetrical. Unless it is a root compression like disc prolapse or something, there can be a root involvement. Is a what you call is a demyelinating radical situation, it will be bilaterally symmetrical. Then when it joins to become the peripheral nerve, there is the situation where you can get an asymmetrical. The disorders of the minor junction or the muscles invariably will be bilateral. So possibility of the motor unit asymmetrical is at the anterior horn cell or the peripheral nerve. So peripheral nerve also can lead to weakness, but usually asymmetric. That's what you call usually get in a case of mononeuritis multiplex. Many of the vasculitis, polyarthritis, not also ISL, many other DDs, many other entities pathologically can produce mononeuritis multiplex, where you get patchy weakness here and there, heavy metal poisoning and all. So in this case, it's not patchy, it's bilaterally symmetrical. So it can very well be element motor unit, less likely to be anterior horn cell, less likely to be a peripheral nerve. That's what is helpful point, because bilaterally symmetrical, it's unlikely, less likely to be a peripheral nerve involvement or an anterior horn cell. It can very well be any of the muscle minor junction radical. So in that situation, one very important point you didn't mention, which should have been mentioned in the history. What is that? You are analyzing the bilateral symmetrical situation, possibility of it being a motor unit disorder, where you would like to narrow down the possibilities among the motor unit disorders. You have ruled out or put the priority of the anterior horn cell disorder and the peripheral nerve down because it is symmetrical. But in the symmetrical, out of the possibilities of muscle, minor junction and radical, which history should have been mentioned there?
Radicular pain.
Radicular pain, no.
Diurnal variation.
It's a diurnal variation, which is so important in a case like this, because at the beginning, you should consider the minor junction disorders also. Few of them may last weeks like this also. So minor junction, which the most important one is the myasthenia, but other minor junctions are also the, which is a short duration, it's a bite, stings and bites. It's a little longer duration, it's a botulinum toxin. But there are points against that being a botulinum toxin and all. But when you're considering the minor junction disorders, myasthenia is possible, but here that is to be mentioned in the history, diurnal variation, fatigability and the diurnal variation. We were discussing about the possibility of it being the lower motor neuron problem, but as you said, there is a bowel bladder disturbance here that argues for it being a UMN problem. So that's a very important, it's a reliable thing in this case, dependable. The day of the weakness itself, the child had bowel problems and urinary problems. That argues for a parenchymal problem. So in what else, what other way this bowel and bladder involvement help you? So you are trying to localize it. Points are more in favor of the UMN and the spinal cord, less likely to be a motor unit disorder because bowel and bladder disturbance is there. So what other way the presence of the bowel bladder disorder help you?
At the level of the lesion, if it is in the spinal cord, the level of the lesion.
Is it the level of the lesion? So you analyze the history. It's less likely to be an intracranial. It's possible for the craniovertebral junction down to the end of the spinal cord. It's less likely to be a Kodaikanna or a motor unit disorder, but bowel and bladder disturbance, most likely spinal cord problem, and there is conus coda situation where sometimes the conus medullaris can have a bladder disease. Anyway, bowel and bladder disturbance is there. Is it helping in the localization of this thing, level of the lesion? When you call it as a level of lesion, what do you mean by level of the lesion?
No, sir, if it was this is a case of all the four limbs are involved. So here it is not important. We already know that the upper limbs are involved. So definitely it is higher up only the lesion.
No, now we are discussing the level of the lesion is above downwards. Once you considering the possibility of a spinal cord problem, two more level or you need to answer. Where in the vertical axis is the lesion? It can be extending above down for multiple levels. It can be in single level. Longitudinal axis completely gone sometimes in few of the pathologies. Multiple level extensive involvement of spinal cord can be the where you need to know which is the uppermost part involved. That is in the vertical axis what you mean by the level of the lesion. It's the other way in the horizontal axis of the spinal cord lesion. Is it in the extradural? Is it in the intradural, extramedullary, extraparenchymal, or in the parenchymal? So that also you need to tell. So where is the level of the lesion? And where exactly in the horizontal axis? Is it an extradural? Is it an intradural, extramedullary, or is it in the intraparenchymal? So that also will be answered here. This bowel bladder involvement means most likely it's an intraparenchymal lesion. That's the importance. It doesn't help you to say which is the level. Level is assessed by different things. Level of the lesion is assessed by the power. Where is the weakness, topography of the weakness, about the sensory level, then in the reflexes. Utilizing all the three, you are localizing which is the level. In the horizontal axis, by making use of these things. For that, you should have included a few more points in the history. So the level of the lesion is very likely to be in the cervical above, because all the four limbs are involved, means it must be definitely above the C4. Up, or maybe the total down from that point, definitely C4 up to C4 there is an involvement. We don't know C4 higher up how much. Definitely C4 is there, and down it may be involved. You don't know, is it a localized form or completely involved? But in the horizontal axis, you need to consider where exactly extradural. That is important again here, because one more point in the history, there is a tuberculosis in the mother. So there can be a situation of a spinal tuberculosis. Of course, 4 years is not a good age for the tuberculosis. But extradural compressive myelopathy, tuberculous cox spine is possible. So that's one of the examples of the extradural. What point you should have asked to locate in the horizontal axis? What all point will be helping you to localize in the horizontal axis? What are the points you'll be asking to say extradural?
Sir, any bone pain?
Okay. How will you utilize the pain in the case of spinal cord lesion? What all ways there can be pain? Pain is two types of pain. One, the pain you are testing, absence of the pain, the negative side of the sensation. The other one is a positive, that is the child experiencing a discomfort situation, and numbness, tingling, whatever sort of positive situation, and the pain experiencing also can be having a localizing value. The pain testing, absence of the pain sensation is useful in the examination. The pain perception in the history, if it is an older child, what details about the pain will be helpful when you take the history for the localization. What are the types of pain which are possible in the case of spinal cord problem?
As a radicular pain
Very
can
good.
be there.
It can be a radicular type of pain. Then
Band sensation.
okay. Band type of sensations, funicular pain, band type of sensation, then vertebral also. See, extradural, there can be pain due to the lesion responsible for the compressive cox spine or osteomyelitis or a trauma, right? That all those things can lead to pain. then your root pain, then funicular pain, and a few situations, rarer but not that common, are Lermite sign. The pain, which is shooting type of pain, are also important in a case of spinal cord pathologies. It may not be relevant for a 4-year-old child. You may sometimes experience this thing in a case of multiple sclerosis. What is the type of pain? Shooting type, the barber chair pain. When you flex the neck, you will get that sort of a pain that argues for Lermite sign. There is another one, which is the radiating type of pain in a case of previously syphilis you had, but nowadays that type of pain is gone. It is not there due to syphilis. You can get that type of pain. So all sorts of pains are possible during the pain. Then later the phantom type of pain. These are all related to the spinal cord. Pain, subjective sensation. Phantom pain is there. Lermite sign is there, and the tabes dorsalis can have pain. So these are all history points about the pain, which will be helpful to say the pathological basis of the problem and the localization in the horizontal axis. The pain, if any of these things are there, it is arguing for a paragamma lesion. Lermite sign is arguing for a paragamma lesion. Tabes dorsalis type of tabetic type of pain argues for a paragamma lesion. Funicular pain argues for a paragamma lesion. The vertebral pain argues for the extradural and the compressive myelopathy. And the root pain. So what aspect of the pain will you ask for to localize whether it's a root pain? So what provokes and what relieves? About the innate pain, here also it's relevant. So what will provoke the Lermite sign? I said fluxion, sudden shooting pain, then root pain. So what history will you take? What all things will elicit a root compression pain? Pain during cough, straining at stools, micturition, and maybe bending. And that's what you test in a case of SLR and all. So all those pain which is down to a particular direction, that argues for a root pain. That also is important in a case of extradural compressive myelopathies. Many of the pathological basis in a child also is there, like a 4-year-old child can have a leukemic deposits there, and some of the neurocutaneous situations that can occur, extradural tumors can occur. When you localize it to the extradural, the root pain argues for an extradural pathology. So when you get a pain, you need to go in depth. In this case, there was some subjective pain child described, but in this case, it was not suggestive of a root pain, but it was a bilateral symmetrical pain. And in that case, how will you differentiate whether it is a neurological basis or a pseudoparalysis in this case?
Here, bowel bladder is involved, so that won't happen in pseudoparalysis.
No, that is arguing for this thing, sir. But the point which you should have mentioned in the beginning of the pain itself is whether the pain was aggravated by any of the movements, passive movements. So passive movement will be possible without any aggravation of the pain. That means it is not due to the peripheral thing. Osteoarthritis or your osteomyelitis or any other painful thing, there will be the limitation and that will aggravate. In any of the neurological basis or hyperasthesia or numbness tingling due to any early phase of your Guillain-Barré you can get, in case of poliomyelitis you can get, many of the edema also, many other situations you can get this hyperasthesia in early period of some subjective sensory feeling that won't be changed by your movement or touching. So that part also should have been mentioned in the beginning. So where are we now with the history, relevant history? When was the tuberculosis in the mother? I wanted to ask about the tuberculosis in the mother.
Sir, it is 4 to 5 years back. Exact duration she does not correctly recall.
That means that the child, this baby was not there at that time.
No, the baby was not
Her
there.
treatment was completed before the conception of the...
Conception itself.
Okay. After that, she's not symptomatic.
No, no, sir.
The mother is asymptomatic now, no weight loss, no fever, nothing to suggest the tuberculosis possibility.
No, no, sir.
Very important, because whenever you get a case of weakness of all the four limbs of sudden onset, this tuberculosis history cannot be ignored, but it doesn't seem to be related. But next thing, so you're trying to localize this thing. Most likely it is spinal cord problem. Definitely it must be extending up above C4, and it must be a parenchymal lesion. That's what we are, where we are now. There comes the next situation, the onset and evolution of the neurological problem. Any neurological problem, you need to analyze the type of onset, course, and progression of the. That's very important. So that is for the pathological clue. So you'll be completing the anatomical localization by your examination, but the pathological basis of the problem, you are analyzing the history and the general examination. So in a nutshell, what way history and examination help you in the analysis? Your localization neurologically is basically at the examination, but the same nature we utilize the history. History may be helpful to very good extent to have an idea about the localization, but that's not complete unless you see the patient. You can't be sure that it is anatomically what you said is right. So anatomical localization is basically by your clinical examination, but the pathological basis for this particular anatomical localization comes from your history and the general examination. So for the very same anatomical localization, there can be different pathologies. It can be infective, it can be trauma related, it can be vascular, it can be nutritional deficiency. Here again, one very important nutritional point which you mentioned, you see, they are vegans, the vegetarian. That's a very important point when you consider a quadriplegia, whether it is a vitamin D12 deficiency. So it can be nutritional problem. There can be heavy metal poisoning situation. So pathological conditions can be any, and the clue you are utilizing from the history point, and there can be examination findings also. So examination findings, suppose I said pallor pigmentation, I'll be thinking more in favor of a vitamin B12 deficiency. Suppose there is a lymphadenopathy, I'll consider more for a malignancy with the secondary deposits. Yeah. Suppose the child is wasted and thin, and I will consider tuberculosis. Trauma, battered baby, and other. Like that, your clue for the pathological condition comes from your history and your general examination. So now, I think the history. Anybody want to contribute or anything what you want to add? Ajit, Vinod sir, your opinion at this stage. We'll move. Okay. Okay, we'll move to the examination. Okay. Yes, examination, Aneeta.
Coming to the examination, general examination. At the time of examination, the child was lying supine on the bed, arms extended and by the side, legs externally rotated and plantar flexed. Paucity of movements of all four limbs was evident. Paradoxical respiration was present. Nasogastric tube was in situ, IV cannula in situ, and central venous catheter was also present over the right thigh. Urinary catheter was also present. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. Vitals, heart rate was 100 per minute, normal rate rhythm, character volume, no radiofemoral delay. All peripheral pulses were equally felt. Respiratory rate was 32. It was paradoxical type of respiration. The thorax was going in and abdomen was moving out while respiration. Blood pressure was 100/70 millimeter mercury in the supine position. on the right upper limb. Saturation was maintained at 99% in room air and temperature was measured to be 37, normal. Then
Okay, in the vital, you go back to the vital. What are the vital things relevant here? Child was observed to be not moving all the four limbs. And what about the sensorium?
The child was alert, sir.
Alert.
Alert.
Recognizing the parents.
Mother and
any words?
she speaks in her own language, Rajasthani language she speaks, and
What
mother
about the
understands it.
amplitude of the voice?
The sound appears to be normal to us, and mother also says that there is no change in the voice.
Voice is normal, but the amplitude is less or?
Mother, to us it seems normal.
Normal. Did she see her crying?
Yes, sir. The sound was very audible.
So what are the point which you will be observing during the cry?
Cry, the sound, the amplitude
What
of the
are
cry.
neurological points are important to be observed while the child cries in this case? Crying is definitely a very important thing which will be very helpful.
So the sound of the cry with hoarseness of voice can be identified, and the amplitude also can be identified, and how long the child can cry. That is the vital capacity can be assessed, and you can also observe the palate while crying. You can look at the movement of palate.
No, the child is crying, weak child, you won't be able to see the contents inside the mouth. Most important is the facial movements. Whether what about the closure of the eyes? During the cry, you can have an idea about the closure of the eye power. Child will be closing the eyes also, the power that, and the facial movements, because in a case like this, especially if it is a case, especially in case of muscle disorders, radical problems and all, there can be a bilateral facial weakness. Bilateral facial weakness is very, very difficult. You are very likely to miss. Unlike your unilateral facial thing, you will describe the deviation. When there is a bilateral weakness, it's very difficult to make out. Sometimes you may miss. That is more important in the case of a GBS-like situation. So, the facial movement during cry, if it is intact, very good. That rules out the possibility. In this case, you should be looking for the eye closure, ocular movements during this thing, and the facial movements during the cry. Of course, about the amplitude of the sounds and nature of the sounds are important. Okay, and as you said, the breathing, definitely it's paradoxical breathing with a diaphragm spared and an intercostal affected. So what does that, how that help you?
If the diaphragm is
spared. Diaphragm means it's a C4 and intercostal bilaterally. So you should be taking a photo, you should be observing the foot end. One side you may miss it because in case it's a one-side involvement. You said it's a bilateral symmetrical. Few of the situation like poliomyelitis and all, there can be one-side intercostal weakness, one-side diaphragm weakness. We during the 70s and 80s, we had many cases of polio where one-side diaphragm, one-side intercostal and patchy intercostal involvement, all were possible. Now we get the intercostal weakness as a part of demyelination. Many of the cases are bilateral symmetrical. So, in a case like this, some of these situations, there can be again the patchy involvement unilateral. If the lesion is somewhere in the thoracic spinal cord and all, the lesion need not be bilateral symmetrical. One side can be spared, one side can be almost normal. There can be a little bit of asymmetry. If it is. So, in this case, it must be higher. You should be taking a video from the lower level, not from the sides. In this case, it seems to be significant bilateral intercostal weakness with a diaphragm spare. Okay, and the very important thing is a pulse rate you mentioned is 100. It's a little on the higher side. Rhythm is normal. Pulse is important. In a patient like this, the vital centers, the breathing, the pulse rate, rhythm, and the BP also. BP is normal?
Yes, sir, 170.
Okay. Did you repeat it again and again? It's persisting almost the same throughout?
Yes, sir. It is.
That's very
There is
important in
no
the vitals. So autonomic, because in any
autonomic
case like
dysfunction.
Guillain-Barré going upwards is important, or any other situation where there is upper spinal cord level or lesion localizing the vital areas in the lower medulla is so important in this case. Okay. So in the general examination, any other relevant clue in the general examination apart from the vitals? Okay, go forward.
And head to foot examination, the head
So
shape.
without oxygen, she's maintaining the saturation.
Yes, sir. Yes, sir. Yes, sir. Head appears normal in shape and size. There is occipital balding present, probably due to position, which means that she is hardly moving. There is no short neck. Her eyes are normal. There is an old burn scar over the left knee, posterior aspect. A pressure sore is present over the lateral malleolus of the left leg. And then there are no neurocutaneous markers or hyperpigmentation, skin rash, or any bite mark. Then the spine, there is no deformity.
So
Spine is
that means
taken.
there is a bed sore on the lateral aspect of the malleolus, means it's a propinous child who's keeping the legs out,
Externally rotated.
externally rotate. Both sides it is there on unilateral
No,
only.
sir. This side only it is there.
Is there any bed sore on the back?
No, sir. Back is normal.
Any
Spine.
skin changes in that area? Why should you look for the skin changes other than this one?
Sir, other
You said
than the
neurocutaneous marker.
Yes,
What is the relevance of looking for a neurocutaneous marker here?
so there can be stroke-like episodes in various neurocutaneous disorders like Moya syndrome. But
So you're talking a blunder now.
it won't happen with quadriplegia. It won't happen with quadriplegia.
In what way? Now you are almost certain that it is a problem somewhere outside the intracranial. It's a spinal cord loss, most likely situation. There, what is the relevance of neurocutaneous marker? Neurofibromas.
Pneumofibromas.
So you should be looking for the parent's face, not on the child's face, because you don't expect the external markers sometimes are there. That may be capillary spots or something like that. That's a very unusual situation that can also sometimes lead on to the spinal vertebral malformations and compressive thing. Many ways it can lead on to spinal cord problems. But that is not I was meaning some other thing about the skin, not the neurocutaneous marker. So previously normal chart. Okay, hyperpigmentation is relevant, especially in the case of the gun. In this case, there is no pigmentation perioral. Knuckle pigmentation is not there. Okay. Any other skin? Any other way skin is relevant in the case of spinal cord problem. Again, autonomic disturbance. There can be involvement. Yes, that also sometimes important. Sweating, flushing, autonomic disturbance can be there below that level. That is important. Okay.
Then spine examination. There is no deformity, swelling, any pits or scoliosis.
Examination usually we'll be doing the skull and spine examination at the end of
yes, sir. It is already mentioned in detail there. There are no contractures or limb deformities. There is no facial dysmorphism in the child.
Okay.
Then anthropometry, weight for age is 10.5. That is her present weight, which is less than the third centile and less than 3 standard deviation. So, and there is grade 2 undernutrition. Length for age, which is grade 1 standing present.
Did you tell about the lymph node? Any no pallor you mentioned?
No,
any lymph node anywhere?
No, sir. It is also mentioned. There are no lymphadenopathy, no.
Okay. No rashes, no lymphadenopathy.
No rashes.
No pigmentation, skin changes. No. Okay.
No skin changes. Then weight for length, there is grade 2 wasting is present. Head circumference is normal for her age.
So it's undernourished child with wasting and grade 1 stunting is the significant. But there is no micronutrient deficiency. Suppose in this case we are discussing about the point arguing for the pathological basis. What are the things in a case like this in the general examination? with the points which will be helpful to localize in the general examination. Second points which will be helpful to say the pathological basis.
Pathology.
Neurological point of view, the attitude and posture of the limbs, expression of the face. The attitude and the posture of the limbs, whether it is a bilateral symmetrical, to what extent it is it a spastic type of thing, is it a flaccid type of link, the attitude of the foot, whether it is scissoring like of thing or plantar flat or it is laterally turned, will give an idea about the tone of the legs by the observation. Attitude of the upper limb also gives the impression about the tone. Of course, hypotonia in this case is evident. And next thing is the expression of the facial expression, which will give an idea whether there is a bilateral facial weakness. And of course, about the sometimes appearance of the ptosis extraocular movement. That is relevant. Few situations where you get suppose it is on the initial days, some of the muscle disorders can present with the ptosis situation, facial expressions. So that also need to be considered. Myositis and all. Myositis, myasthenia gravis and all. Few of the expressions and a few of these things will be in the extraocular ptosis and the facial expression part. In this case, that is normal. Expression is normal. Ocular movement is normal. Okay. Basically, it's in the this part. Okay. There is no evidence of micronutrient deficiency, heavy metal poisoning, no evidence of a malignancy, tuberculosis, child is not febrile. Okay, that much is the pathology. Okay, to go to the CNS examination. Anthropometry, it's an ill-nourished child. Okay. There is no standing. There is no standing in this case.
It's a grade 1 standing.
Okay.
System examination, nervous system, higher mental function. The child is alert, oriented. Her speech appears to be normal. Language also appears to be normal. Memory, as far as I could test, it appeared normal. Attention was not able to be tested. Cranial nerve examination, smell appears normal.
So in this case, the higher mental functions, conscious level, speech, except for the amplitude of the voice, speech was normal. The comprehension and expression is normal. There is no slurring of the speech. That is the important thing about the speech, because we are postulating the possibility of the spinal cord. If it is a higher level spinal cord, craniovertebral junction problems, there can be some of the situations where cerebellar signs can be there. So cerebellar involvement can lead to subtle clues. The speech can be altered. Okay. Speech is normal.
Second cranial nerve, visual acuity, she identify objects at 1 meter. She cannot count the fingers. Visual field could not be assessed. Color vision was not tested. Pupillary reflexes were normal bilaterally. Fundus, there is no evidence of optic neuritis or papilledema. Also, there are no choroid tubercles in eye examination.
Very good. What are the things which you are interested in this case?
Sir, in eye examination. Eye examination, we look for evidence of tuberculosis, like
even though you didn't get any evidence of this thing, choroid tuberculosis. Okay, it's more important than that.
Optic neuritis is important
because one very important combination in a case of spinal cord pathology, skipping unrelated involvement, Devick's disease, which we previously encountering this thing, optic neuritis and visual problem, visual acuity. It's very difficult to test in this child. Still, did you test in both eyes separately?
Yes, sir.
Vision is normal. That's again important because there are two situations where this can occur. One thing is in Adam, where there can be separate lesion responsible for the optic nerve. There can be lesion in the spinal cord. The other way, multiple sclerosis, again, Devick's disease. Both ways, the visual testing, whether it is, there are a few points to differentiate between these two. Is it bilateral? Is it unilateral? That's all important. In this case, vision is normal, fundus is normal. You don't expect a papilledema or raised ICT feature in this case. Okay. One more thing. 3, 4, 6 normal.
There is no ptosis. Eye movements are full and equal in all directions.
So what way that will help you?
Ptosis is not
normal
there.
Extraocular movement, no ptosis situation.
Ophthalmoplegia is not there, so there are
So
combination
it will be
similar features.
considered during the discussion in a case of motor unit disorder, radicals situation. There is a GBS variant where there is a extraocular movement, but we have discarded that possibility and we are now in the spinal cord. Here in this spinal cord, in this case, we are localizing a lesion very higher up in the spinal cord. Is there an relevance of the extraocular movement?
As in neuromuscular junction disorders.
No, that is out. We didn't consider, we are not considering the neuromuscular or a muscle disorder here. It's most likely it's a spinal cord parenchymal lesion. Spinal cord parenchymal lesion higher up in the cervical. There again, there's a need for your extraocular movement. Is there any link there? This is very important, very useful thing. The visual part, second nerve, we are considering the possibility of an acute neuritis in case of edema or multiple sclerosis. Here now you are referring to the extraocular movement part in a context where you are suspecting a parenchymal spinal cord problem, upper cervical. What is it? Another group of disorders very closely related to the immune-mediated distractions, NMO. Yes, there can be involvement of the brainstem, upper spinal cord, and there can be extraocular movement problems. So that's again possibility in a context like this. And that is one very important thing in this case, because you gave medicine but the child is not responding. Very, very important thing. Few of the group of disorders where you may not get the response, this is one of the bad situation. The extraocular movement is very important. Okay.
Then cranial nerve 5, there is no temporal holding, deviation of jaw. Sensations are present bilaterally. Then masseter is normal, jaw jerk is present. Corneal reflex not tested, but conjunctival reflex is present.
Corneal reflex not tested, jaw jerk is present, normal. Okay.
Then cranial nerve 7, there is no facial asymmetry is not there, and she's able to close her both eyes. Eye closure is normal.
When you describe here about the facial, there is not much importance of the facial asymmetry or deviation. It's the overall assessment of the power of this thing. Like when there is a bilateral facial weakness, the importance is the deviation is not there. About the creases, about the closure of the eyes, about the drooping of this thing, the subtle features of a weakness, drooping of this thing, loss of these creases and all. That argues, and of course the movement less during a cry, that is important. Do you think there is a weakness? No weakness.
No, sir. No, sir. No weakness.
So all the trainers up to this is normal. So we are more interested about the lower medullary cranial nerves. What about the 9, 10, 11, 12? Okay.
So 9 and 10, uvula is central. Palatal movements are equal with gag reflex present. There is no nasal twang, no nasal regurgitation, no swallowing difficulty.
So this is one point which I missed during the history. We should have gone a little depth about the swallowing and the chewing, swallowing. Was there any difficulty in this thing? In any patient, when you are suspecting a GBS situation or a polio, whatever, where there is a weakness in the upper spinal and the lower cranial thing, this is very important because that has got a bearing on your prognosis and management. Because lower cranial involvement is very important. Very nearby is your respiratory vital centers, and that is impending danger. And the clue about this thing is the feeding pattern, especially the swallowing, aspiration of the liquid diet. Very important to ask about the swallowing, especially intake of the liquids. Very important. In this case, was there any difficulty? No.
No, sir. No difficulty.
Okay. So in this case, you said the dark reflex is present. Sensation 9th must be normal, and the 10th also is normal.
Then cranial nerve 11. Here, the sternocleidomastoid tested to be normal, but she is not able to shrug her shoulders. Trapezius is not working.
So what about how will you? What are the diagnostic importance of this 11th nerve assessment?
11th nerve, there is it is a spinal nerve actually. So
there is a cranial component
cranial
and the
and
spinal component.
spinal
Both are there. So you need to test for both this one and the sternocleidomastoid both. In this case, you feel the elevation is not there.
Not there.
The spinal component may be affected. Okay. What about the tongue? No atrophy, no fasciculation.
No atrophy.
Don't expect
no
the deviation here. So child can put to
power
the
is not. Power of the tongue appears normal.
Okay. Okay, hold on.
Then motor system. Child is lying supine on bed, arms extended by the side.
In short, higher functions and the whole cranial nerves are normal. You didn't get anything.
Except for trapezius.
Except for 11th inner spinal component. Okay.
Spinal component. Then bulk inspection, there is no wasting. Bulk is comparable on both sides. Measurements also, the bulk is comparable. Then tone, there is arms are extended.
Inspection, there is no fasciculation or anything.
No, sir, no fasciculation.
In the general examination, of course, there was no abnormal movement or any abnormal position. It was not there. Okay, we didn't expect that.
Here, the general tone appears that the child is hypotonia. The palpation also, muscles are flabby to touch, and generalized hypotonia is present with increased adductor angle and popliteal angle. Shawl sign is present, and range of movements are increased over all joints. There is generalized hypotonia. Then muscle power. Sorry, muscle power. Now the child, I have examined the child not on the first day, on the subsequent days only. So there is some changes from the first day. Here, the shoulder shoulder extension flexion, it is possible on the left side. Adduction abduction of the shoulder joint is possible also on the left side.
There is asymmetry at this stage now.
Yes, sir. At this stage there is asymmetry. And on the right side, left side there are more movements compared to right side. Right side there is only pronation, supination at the elbow joint is present.
Okay.
Initially it was not there. But lower limbs, there are absolutely no movements. Okay. Neck movements are preserved.
So when you go up, there is an asymmetry where right side is more involvement. Okay. And lower bilaterally symmetrically, zero power.
Symmetrically.
Okay. In the grip, everything on the left side comparatively better power. Grade 2, 3 power is the. There is no proximal distal difference. Little bit better power in the left side proximal.
Left side
proximal. The left side proximal is little better power. Right side is zero power throughout upper limb and lower limb. Neck holding flaccid.
No, sir. Neck holding is possible. Against resistance, she's not able to flex and extend, but otherwise she's able to do against gravity. It is possible.
Neck holding is possible.
Neck holding.
Okay. Diaphragm is present.
Diaphragm is preserved.
So, shoulder abduction, is it possible? So, from the observing the weakness of this thing, intercostals are weak, upper limb grip is weak bilaterally, and the shoulder and the flexor part of the left part is almost normal. So which are the motor things which are comparatively less affected on the left side? Diaphragm is spared. That means C4. Okay.
C4 is intact.
C4 bilaterally. But corresponding to the limb C4, where is it? Abduction of the shoulder. Deltoid is C4. Deltoid abduction is the shoulder. C4 is a deltoid. I think in this case, diaphragm bilateral is normal and abduction is normal. This side is abduction affected. Did you test the abduction on the left side?
Yes, sir. Right. Shoulder abduction is possible on the left side only, not on the right side.
Not on the right. That side, but diaphragm is normal.
Diaphragm normal.
Okay, all the other things are 0 or very less. See, the brachial plexus is from 5, 6 down. So that is reflected in the hand and the flexion, extension, everything. On the right side 0, left side a little bit. So in the spinal cord, in the parenchymal lesion, there is a little bit of asymmetry starting from C4 down. C4 comparatively intact, C3, C2 down, there is a bilaterally symmetrical but little sparing on the right side. So that is the possibility.
These movements were not present initially. So this has been like over after 20 days. So
gradual improvement. Maybe after some time it's gradually improving on the left side. Okay. That's right. Finger movements are absent both sides?
Sir, finger movements are just flicker of movements only present. She's not able to make a grip.
That means 5, 6. That's how you come down in the brachial plexus in the motor thing. Abduction, shoulder, and everything somewhere 4 contributes. But 5, 6 uppermost chord is originating from 5, 6. So proximal. Then down the smaller muscles and all are from the lower thing. So invariably that part will be affected. So lower cervical cord is affected. Okay.
Then deep tendon reflexes were absent on right side and left side despite reinforcement.
Even during this after this 25 days absent. What about the plantar?
So superficial reflexes plantar is also absent.
So far it's remaining flaccid, areflexive.
Areflexive.
Okay. So by the examination of the power and reflex, you can't say whether it is a human. That's a problem. You were postulating the possibility of the spinal cord because the bowel bladder involvement is there. You expected a human, but the weakness is significant. But the tone is remaining flaccid, reflex is asymmetric, absent. Upgoing plantar is not there. Okay. Abdominal reflex is absent.
Is also absent. All quadrants.
Okay.
Anal reflex is also absent. Then sensory system. The only touch is appreciated just above the nipple, and there is no zone of hyperesthesia. Temperature and pain.
So from the power and the reflex, so in the localization, it's definitely a spinal cord problem, parenchymal problem, and the lesion now with this thing is the lower cervical starting down from the C3. You don't have an evidence of a craniovertebral junction or at a higher level, and C3 down is the possibility. And next you are going to for the localization by sensation that need not correspond. Sometimes you may get the localization based on the power, based on the reflex, based on the sensation at different levels. So what is the localization by the sensation? So when you talk about the sensation utilization for the localization, 3 different pattern of sensory testing is important. One is the tract type of sensory loss. The other is the root type of sensory loss. The other is the cutaneous nerve type of sensory loss. The root type of sensory loss, you know, the distribution of the dermatomes. So that diagram you remember. The tract type of sensory loss is the one thing which is there in the case of spinal parenchymal lesion. The peculiarity of the tract type of sensory loss is one modality alone is involved and that corresponds to the tract. One side the spinothalamic tract is involved means the other side pain and temperature is involved, the rest of the modality is retained. So one modality only and that is involving the side as such, not a dermatome. So tract type. you expect a tract type of sensory loss, and maybe with this thing there can be associated level of the element type of this other type of sensory level also can be there. Okay, go ahead with the.
Then pain and temperature is also appreciated and
Touch
at the
vibration
same
position,
level.
sensor only touch appreciated, that too just above the nipples. Only touch vibration position sense is not there.
Not there.
And what is the uppermost level? You can't appreciate it. Vibration test. The vibration gone means posterior column is involved. Bilaterally, posterior column is gone. Okay.
Then pain and temperature is also appreciated.
Pain and temperature is appreciated throughout.
Yes, sir. Throughout. No, sir. Just above the nipple, at the same level. Below nipples,
so below
it is not appreciated.
Below the nipple.
Well, there is no appreciating touch, vibration, position, pain, or temperature.
No modality of sensation is there bilaterally below the nipples. All the modalities are absent.
Yes,
okay. Sir. Okay. Above that.
Above that, touches, vibration, she could not cooperate, and positions she did not appreciate, but pain temperature is appreciated.
Pain temperature is appreciated. Pain temperature means spinothalamic tract by both sides it is appreciated?
Yes, sir. It is appreciated both sides.
Above the nipples, both sides?
Above the nipples.
Both sides it is at the same level?
Yes, sir. Same level.
Same level. Both sides above the same nipple, you are appreciating the spinothalamic tract. That means, so you need to have an idea where is the in the horizontal axis of the parenchyma involved. In a case where the horizontal section posterior column is in the back, where the vibration, position, light touch will be going. Spinothalamic is in the sides. Corticospinal, lateral corticospinal, and the spinothalamic are there in the sides. So up to the nipple, everything is involved. Above the nipple, there is a disparity between this thing. You are having a predominant involvement of the posterior tracts, but sparing of the spinothalamic both sides. So anterior 2/3 and the posterior 1/3 of the circle. Just because you cut it, the posterior 1/3 is occupying the posterior column, gracilis and cuneatus, carrying the vibration, position and all. And anterior 2/3, you are having anterior corticospinal, lateral corticospinal, cerebellar ascending, and the spinothalamic tract and all. So in this case, the posterior tract is involved even higher up, above the nipple. But above the nipple, the lateral spinothalamic tracts are spared. Okay. So, but the thing is that corticospinal is not spared here, because if the above the nipple corticospinal was spared, you will be getting the upper limb normal, but upper limb is involved bilaterally. So corticospinal bilateral, lateral corticospinal is involved there, but the corticospinal near is the spinothalamic. Spinothalamic is spared. Okay, spinothalamic is spared. Definitely the bowel and bladder is involved. You don't know what is the type of bowel and bladder because the child is catheterized. You need to have it when you analyze the bladder. You need to differentiate between UMN and LMN, but in this case it's not possible because the day onwards the child was catheterized. So in this case, we imagine the child is having a bladder involvement. That means near the bowel, bladder fibers coming down are very near the central canal. So parenchymal near the central canal, and the spinal cord a little side. Corticospinal is still lateral. So in the axis, when you are getting a patchy involvement where the posterior tracts are completely affected, corticospinal is affected, and the spinal canal is involved, but bilateral spinothalamic is comparatively spared. So few of the tracts are spared. And what about the cortical sensation? Cortical sensation is not needed here. Actually, you need not, because cortical sensations are tested in a case of intracranial third order neuron problem where every lower sensations are intact. So that is should not have been mentioned there. Okay.
Then
so from your sensory examination, what is observed is pain and touch is appreciable bilaterally up to the nipples, and there is a little bit of upper spinal, thoracic spinal segments, a little anterior part is comparatively spare, predominantly posterior part is involved. Okay.
Then cerebellar signs, there is no dysarthria, no nystagmus, no abnormal movements over the body. Other cerebellar signs could not be tested in this patient.
Okay. So it's very difficult to test the cerebellar signs in the presence of a limb weakness. Only what you can assess is by the speech and the nystagmus and all. Okay. Forget about this.
Bowel and bladder is involved, and per-abdomen fecal mass is falcum. Bladder is voided through CVD.
Okay.
In skull and spine, there is no deformity, no kyphosis, scoliosis, gibbus.
So more important is to see the spine, because when you are postulating the possibility of a lesion of the spinal cord lesion, upper cervical, what you are interested is the tenderness and the gibbous deformity. Where will you look for the tenderness in this case?
The lesion is high. We are postulating that the lesion is higher up.
So very unlikely for a lesion to be at the C3, because it must be a little longitudinal down lesion. It cannot be one point lesion. Is very unlikely to explain this one. C3 is the uppermost part, but down it can be extending to many levels down. So if it was C3 only, which spinal vertebral segment you look for?
C2.
When you get a spinal level, what is the corresponding vertebral level? How many spinal segments are there?
Sir, 8 spinal segments and 7.
So vertebral level? 7. 7 vertebra. Okay. So minus 1.
Minus
so
C3.
1. Okay.
C2.
Okay. So in this case, is there any gibbous or tenderness there?
No, sir. No palpation. There is no tenderness.
No shortening of the neck you mentioned. There is nothing obvious in the. That is the spinal examination more important. Now the skull. Okay.
Then other systems.
Any positive findings?
Sir, anal opening. There is no abdominal masses other than the fecal mass. There is no other mass. We are suspecting as a malignancy. There is no mass.
Other systems are normal. Okay.
The systems other than the paradoxical respiration, there is no.
Liver spleen is not there. Chest examination is normal. There is no
paradoxical respiration is there.
Apart from that, there is nothing. Okay. Other systems, anything?
Musculoskeletal, there is no dislocation, no contracture.
Okay. Okay. Peripheral nerve thickening. Did you palpate the peripheral nerve? In this case, peripheral nerve palpation also is important. So at the end, skull and spine and the peripheral nerve palpation also is important. Okay. So at the end of the examination, your localization, where do you localize and what is the most likely pathology? Summarize.
Summary is a 4-year-old female from Rajasthan. She is partially immunized for age, normal development, presented with acute onset flaccid quadriplegia, maximum deficit attained in 3 to 4 hours, and involved in motor system, sensory system, no autonomic manifestation. Bowel and bladder is involved early and normal sensorium. Non-examination, we have quadriplegia with generalized hypotonia, absent reflexes, and a clear sensory level is present, and no cranial nerve is involved.
So most likely, where is the localization, anatomical localization?
Spinal cord.
Spinal cord. As you said, must be in the lower cervical or down also may be involved. Okay. What is the pathological basis of this condition? That's a question. So how will you say it's a pathological basis? The onset and cause of the evolution of the problem?
It is very acute onset
very
and
acute,
rapid evolution.
Occurring within minutes to hours. So what does that argue for? So when you get a very rapid within minutes of occurrence.
So it is not a compressive myelopathy. We should think in terms of a non-compressive myelopathy, like a transverse myelitis.
Why can't it be a compressive myelopathy?
Usually there would be symptoms preceding that. There is no, for a child it is difficult, but there is no symptoms preceding.
No, in this case, when you get an acute onset, there are two possibilities, either vascular or traumatic. vascular or traumatic, you may get a vascular. What is the vascular basis of the quadriplegia?
It can be a stroke and spinal artery.
Antispinal. There is no need for antispinal artery occlusion can present with a quadriplegia like this if it is happening within minutes. Okay. Trauma also is equally important.
There is no history of trauma.
Okay, there is no need for history also. What's the classical situation? The
atlantoaxial
dislocation which can happen in the case of the prone case. Atlantoaxial dislocation present just like this within minutes. Sometimes it can happen. And the cox spine, fracture spine. This again compressive myelopathy. You can get a sudden onset. So just because of the absence of trauma, I cannot rule out that possibly sometimes trivial trauma can lead on to either of these things: compression at the craniovertebral junction or a tuberculosis or whatever vertebral collapse that is possible. So pathology, if it is within minutes, these are the possible. But here, is it in minutes? It's happening over a few hours. It progressed from that suddenly, but it progressed to within hours. And what is the other point which less likely to be due to vascular? Definitely vascular is to be considered.
The maximum deficit will be at the onset.
What are the other vascular? You said it's antispinal artery occlusion. Is it a male child or a female child? It's a female child. In a male child, always consider bleeds, extradural, hemophilia and all. Sometimes bleed can happen. Acute bleed also can lead to collection of the blood. Trauma leading to minor trauma leading to collection of the blood. Rarely extradural compression is possible. So antispinal artery is the commonest thing. But in this case, it evolved over a few hours. It's arguing little against the trauma and vascular. So what is the next possibility?
Inflammatory disorders.
Like
transverse myelitis or infection.
What do you call transverse myelitis? You call it as an inflammatory disorder?
No, sir, it is.
Which are the inflammatory disorders? You say, as you said, the inflammatory disorders which can present like this. In this case, you consider inflammatory disorder? Infections?
Connective tissue disorder. Infections can be happening. Infectious myelitis can present. Or
that's all rare. The infection responsible for the paraplegia are related to the bacterial infections. That's all rare. In this case, there's no fever. You need not consider abscess, osteomyelitis, or the extradural collection like the pus collection. It's very, very unlikely. You don't consider infection as a cause in this situation. And when you call it a myelitis and all, infectious directly leading on to myelitis is so rare unless it is an immunocompromise and all. There's no need to consider that. So it's a demyelination. It's not inflammatory. You're confusing with the infection. Infection is a different thing. Infection leading down to paraplegia can occur due to extradural pathologies. The parenchymal as such due to infections are less common. The infection as such leading to parenchymal are all viral, especially in case of immunocompromised situations. Not in an immunocompetent. It's very unlikely for a parenchymal infection to lead on. There are entities in an immunocompromised situation where a few of the viral can lead to this sort of a paralysis that evolves not in hours, that will take some more time. So most likely, which is happening over hours, must be demyelination. It's very unlikely to be due to the vascular. Vascular can occur sometimes gradually evolving situation, but unusual. So most likely this seems to be a demyelination. What demyelination is most likely?
The transverse myelitis is most.
I'm hurrying a bit because time is 1.5. Okay.
Transverse myelitis is most.
Okay. Transverse myelitis actually, okay.
It occurred rapidly over hours and sensory level is present. Bowel bladder involvement is early.
Okay.
So it can. Then a GBS could have been considered, but we are not considering that.
No need to consider any of the other things. You have reached this situation, then there is no need to discuss again. It's a spinal cord problem, parenchymal problem. It's at the lower cervical down. It most likely to be demyelination. What you said is right. It's a transverse myelitis. situation where maybe there is no other thing to consider edema or something associated. You may get an intracranial plus spinal cord situation where you need to consider demyelination, central demyelination, Adam-like situation, but there is nothing to support your Adam concept, no alterations of sensory, nothing to point to that. So it's basically predominantly spinal cord parenchymal thing. So your argument that it's a transverse myelitis is right, but it is not complete without considering a little bit more about it. There are different types prognostically. In this case, especially it's static for the last 25 days, means it's a bit worse situation of a spinal cord transverse myelitis. It's a worse variants like hemorrhagic encephalitis and hemorrhagic myelitis and all, following few of the infections like measles and all, sometimes lead to severe form of this thing. So I think it must be some worse form of a transverse myelitis, most likely. So what did it turn out to be? I don't know. You just tell me to complete the diagnosis.
It is an acute flaccid. Sir, shall I?
Go ahead with the investigations now.
Sir, we took an MRI for this child suspecting transverse myelitis, and we saw that the whole of the spinal cord is involved. From C1 to the conus medullaris is involved. So this is the spinal cord, the report of it, and the entire cord is involved.
You didn't get the transverse cut sections, only the longitudinal sagittal one. And the only problem is that you didn't show the cervical and thoracic, which we were interested. Actually, we were not interested in this the mid thoracic down, but we were interested in the lower cervical and the upper. That part you didn't show. That also should have been shown here. Okay. So what was it?
So it is a long segment, longitudinally extensive transverse myelitis involving C1 to conus medullaris.
Okay, that's enough. Then, any other investigation?
Sir, other investigation, we did a lumbar puncture and CSF study, which turned out to be normal. And we also sent MOG antibody and aquaporin P4. Aquaporin 4 was also sent. But those came out to be negative.
Actually, what I wanted was to see the cut sections, the longitudinal sections in the higher level, where few of the findings are so typical and arguing for your NMO. So one thing which you need to, in the context like this, you need to consider that also, where the longitudinal streaks of this demyelination like thing will be there in the parenchyma. That would have been more arguing. In this case, if there is no response to your medication, you need to consider in line with that NMO disorder and all. But it's very unlikely for that to come down to this the lumbar area. So that's a point against. If it was in the brain matter, the brain stem and the upper spinal cord, NMO is more likely. But in this case, it is coming down to this extent, a little less likely. Okay. Then?
Sir, ophthalmologically, the child, it was normal. There was no evidence of optic neuritis, and MRI brain also did not show any lesions or any lesions on the optic nerve. So we couldn't find anything correlating.
You stop sharing the slides now?
Yes, sir. I was looking for the other sections.
If it is there, okay. Otherwise, we'll wind up.
Okay, sir.
Any questions? Any questions? I'll just check to look for. So I think we'll stop here. There's no need for.
Okay, sir.
It's all answers to the previous discussion, I think. Okay, that's right. Anybody else want to ask questions now? Priyanka? Any more slides? No, nothing. What's relevant to this type? Nabil, can you allow these people to talk?
Yes, sir. I have enabled unmuting option.
And I think better method is to talk rather than chat.
Yes, sir.
5 minutes, 5 more minutes.
Hello, sir. Can you hear me?
Yeah.
Hi, sir. Sir, shawl sign is usually we appreciate in dermatomyositis, no, sir?
Yeah.
How is this relevant in this child, sir? Like,
in this case, we don't consider any of the peripheral problems because everything is arguing definitely for a human thing. There is no need for considering the muscle disorders. When we approach the case itself, we are systematically ruling out the motor neuron disorders. There is no need for considering any of the peripheral muscle, myelin junction radical. It's a spinal cord problem only. There's no need for. But why do you ask about the short sign here?
that was actually mentioned in the case findings, shawl sign.
Sorry, I didn't notice that. It's not relevant. It's not relevant.
Okay, sir. Thank you, sir.
That was mentioned as a hypotonia, that the limbs can be extended to the other up.
Hypotonia in this case, that is again very important. 25 days it's over. Even now you're getting the floppiness. Child definitely must be, it's a worse prognostic type of a central lesion. Sometimes within these days, the tone is remaining same, reflex is not recovering, means ultimate prognosis is very poor. Some of the situations of the central parenchymal lesions, it may remain like this, prognostically bad situation. I don't know what exactly is the basis of the severe form of a hemorrhagic myelitis. There are some other things, I don't know, theoretical aspect of it, some of the entities. Nabil, can we wind up?
Yes, sir.
Hello. But thank you all for listening to this session. Maybe some other time we'll come with some other cases. Thank you all.
Hello, sir.
Thank
you, sir.
Hello, sir.
Bindu undu avade. Bindu aanu varanthanu parane.
Sir, in this case, have they ruled out this autoimmune inflammatory process like MOG, anti-myelin oligocyte, ganglioside, emoji?
Emoji അയച്ചിട്ടുണ്ടെന്നല്ലേ പറഞ്ഞേ അനീറ്റ?
Yes, sir. അത് നെഗറ്റീവ് ആയിരുന്നു.
Okay.
Dr. Bindu is my student. She is a pediatric neurologist now in Chennai. They just joined. Anything else you want to add, Bindu?
No, sir. It was very perfect. She had presented very nicely. Everything was systematic and fine. Nothing more to add. I just want to ask about this. That's all. Thank you, sir.
Thank you, Bindu. Okay, Nabil, thank you. We'll wind up.
Thank you, sir.
Thank you, Aneeta. You did very well. This is the second time we are meeting. It's interesting. I enjoyed the case presentation because I always enjoy without knowing anything. That's a better method, I think. Even if I go wrong, I don't mind. But this time, I think we were almost near the target. Okay, thank you.
Thank you, sir.
Good night.